Good afternoon, everyone. We'll give people a couple of minutes to, or a couple of seconds to log on. As you heard, this is being recorded, and we'll place the recording on the Berman Institute website. All right, welcome. So a new year for Ethics for Lunch. My name is Mark Hughes. I co-chair the Hospital Ethics Committee and also a faculty member in the Berman Institute of Bioethics. And Ethics for Lunch is co-sponsored by both the Ethics Committee and the Berman Institute. We have monthly sessions as an opportunity to talk about clinical ethics issues with the hospital community. I think several of you may be familiar with Ethics for Lunch from previous years, so good to see you all again for a new academic year. We're going to hopefully be in person or at least hybrid at some point this academic year. We had hoped that we might be able to accomplish that for this session, but that wasn't possible. We did in fact order lunch, so that was delivered to the Berman Institute, which is in Deering Hall on Ashland Avenue. If you are on campus and wish to have lunch today, you could walk over to Deering Hall and somebody will open the door for you and give you a lunch. So an opportunity, even though we're not in the Chevy Chase Conference Center. We will let you know for future months when we send out the announcement whether it will be hybrid. So we're going to attempt both the online and in-person way of presenting it. Just to see what the interest is in in-person attendance, I have a little poll that Deja Thomas, who is our administrative coordinator for external affairs in the Berman Institute. So if you could answer this poll question, I think we have to open the poll and see what your answers are to this question. If Ethics for Lunch were hybrid, would you attend in person? And knowing that if you come in person, you might actually get a lunch, a free lunch. So yes or no to that question. We'll give you a minute to answer that. Deja, you can sort of gauge if we've got 38 participants, whether we've got a quorum for voting, if people have been able to respond. And let us know the results, show those results when we have them. All right, so a lot of you want to be in person. So 79% chose the in-person option. So we would still, I guess, have the virtual option available for those that are off campus or couldn't make it in person, but we would welcome to see you once we know that we can use the Chevy Chase Conference Center in the Zayed building on the main floor. So for those that want to mark their attendance today with the CME office, you'll see at the, I'll show you, I'll do a share screen here and give you the information about this session. You all can see that. So if you text to the number 443-541-5052, put in the code 43688, that'll get you verification of your attendance today. So today's session is going to be talking about determining the appropriate authorized decision makers. So when patients don't have the capacity to make their own decisions, we may need to rely on family or friends to be decision makers for them. And there's a process for determining who the appropriate decision maker is in those circumstances. So we're going to walk through a few scenarios to think about that. We have a distinguished panel to talk about that for today. So I wanted to have each person introduce themselves. Janet, maybe you could start.
Sure. Good afternoon. I'm Janet Coleman. I'm one of the risk managers at Johns Hopkins Hospital and and counsel for the health system as well.
Thank you. Caitlin?
Hi, I'm Caitlin McGeehan. I am a nurse with some cardiac background previously in the CCU, have been on the palliative medicine and patient consult service now for several years, and also a member of the ethics committee.
Allison?
Hi, good afternoon. I'm Allison Mitchell. I'm a social worker currently with the palliative medicine team, and I came to palliative medicine from heart and lung transplant, and I am also a part of the ethics committee.
And John?
Hi, I'm John Ponala. I work with the Department of Spiritual Care. I serve as the surgery chaplain and the family advocate coordinator, and also I'm a member on the ethics.
Great. So we'll hear from each of them as we walk through these scenarios and figuring out the decision maker. So these are our objectives. So sometimes there's a legal hierarchy that we need to think about, but there also may be, more dimensions about who's the ethically appropriate authorized decision maker. So think about that. Reference to specific Maryland law about that hierarchy of surrogate decision makers, and then how that might bear on particular kinds of decisions, especially life-sustaining treatments, as determined by the Healthcare Decisions Act, what those surrogate decision makers can and cannot do in terms of making decisions for a patient. So I'm going to walk you through a case and just have you think about it, and then we'll hear from the panelists about how to approach a similar case or other cases where this issue of decision makers needs to be determined. So JR is a 72-year-old male. He has advanced ischemic cardiomyopathy, so an advanced heart disease. He is admitted with an exacerbation of congestive heart failure. They attempt to remove fluid, so through diuresis, but that affects his kidneys, so he has worsening renal insufficiency. To help with heart function, he's placed on a medication called milrinone, which is given as an IV infusion. And then on hospital day 11, he develops an aspiration pneumonia. Aspirates into his lungs, that progresses into a pneumonia, and that requires oxygen all the way to needing high flow nasal oxygen. So through the nose, but a high rate of delivery and trying to get the air in to make sure he's getting enough oxygen. He continues to do poorly. He's deteriorating despite these maximal medical therapies, including antibiotics and the oxygen. There is concern that his respiratory status is getting worse, that he might need intubation and mechanical ventilation for this worsening hypoxemia, this low oxygen level. In his distressed state, he is delirious, and the team is concerned that he may lack decision-making capacity. He has 3 adult children. His daughter and son visit regularly and are seeing him at the bedside. His oldest son visited once early in the hospitalization, but has been difficult to reach since then. When the patient is asked, so he's sort of in this obtunded state, he's delirious. He does say, well, who do you want to make decisions, or who do you want to help us make decisions? Says, well, I'd like my son to be involved in medical decision making. That's about as much as we can get from him. But also visiting the patient, he has a significant other of 40 years. They live together. They're not married, but they've been together for a long time. The patient is divorced from his first wife, who is the mother of these 3 children. And when they are asked, at least the 2 children that are in the hospital, when they're asked about who should be the authorized decision maker, the 2 children think that his significant other should be the decision maker. The team is trying to reach out to the oldest son. When they actually do reach him, he says, well, I think my father should make his own decisions, and sort of indicates that he may not want to be involved in decision making, even though his father requested his involvement. So there is a family meeting to sort of explain the patient's clinical status, the 2 children, his significant other, are present at that family meeting, they say, you know, the patient had previously told them he did not want to be on a ventilator, even if we're for a short period of time. And currently, the patient is not able to say one way or another what he wants. So the clinical team is faced with the issue of what should they do, knowing that his respiratory status is getting tenuous. They might otherwise, in other circumstances, think about intubation and mechanical ventilation. But now we've heard, at least from the family that's present, this may not be consistent with previous wishes of his. So let me see what Allison thinks about this case.
Thanks, Dr. Hughes. So I think wearing my social worker hat, whether a social worker as my role with palliative or on the unit, I think taking a step back from this scenario, it really highlights the importance of having a good psychosocial and social history assessment for our patients. Sometimes if our patients are coming into the hospital without capacity or with concern that they'll lack capacity very soon, first and foremost, we look for an advance directive, asking the patient or family members and friends if there's an advance directive, either in writing or an oral advance directive that's been done, or a healthcare living will, power of attorneys. These are the phrases that I've used to see if there's any type of documentation, because that would be the gold standard of who we look for to make decisions. In absence of having any kind of formal document, again, it goes back to the importance of a good social assessment and knowing, is the patient married, or do they have a domestic partner? If there's children, how many children are there? If there's adult siblings, how many adult siblings are there? Are they biological or adopted siblings or children, or are they step siblings or children? Really sorting out, what could be a complex social circle for our patients is really important in terms of identifying the appropriate surrogate decision maker. Sometimes family members, when they're asked these questions, can come with some defensiveness of, why are you questioning my relationship with my loved one? And what I've done in those instances and what's been helpful to ease some of that tension is really explaining why we're asking the question. I think we should do that for any question we're asking a patient or family member, is to know the reason why, and explaining that this is part of good health care for someone's loved one, ensuring that we're going to the appropriate surrogate decision maker, or ensuring that we're following a document, an advance directive or healthcare living will, as the family's loved one would want. And it's also important as we're doing this social history is to define what a family member is to that person. So for instance, we'll give the example of, we were working with a gentleman who wasn't married. He had, his mother was living, his father had passed away. So under the surrogate law, he had no siblings, his mother would be his decision maker. Although at one point, there were a couple of gentlemen at bedside who identified as brothers, and kind of for all intents and purposes, they grew up together, kind of raised by each other's family, but were kind of brothers by name, not brothers biologically or adopted brothers. And so those relationships are important to tease out. In this case, we have an identified significant other. They're not married. And so I think keywords to listen for are significant other, fiance, partner, boyfriend, girlfriend, a friend. What does that mean? What is that relationship? Do they live together? I think these are all questions we would ask as we're teasing out the social circle. And so those are some of the things I would think about, again, kind of using my social work hat stepping in. But I think this is, figuring out who the appropriate surrogate decision maker is not just the onus of the social worker or the primary team. It's really the onus of everyone as part of the care team, ensuring that we're going to the appropriate decision maker. And certainly if there is an advance directive in place, that we're following that per a patient's wish.
Great, thank you. So Janet, from a legal perspective, if you're thinking about this case, and we've done this social assessment and tried to figure out what the relationships are, and you're hearing that there are these 3 children, there's the significant other, how would you, and we haven't heard about the existence of an advance directive, how would you think about determining from a legal standpoint the appropriate decision maker?
Sure, and I must say this is probably the most frequent call to the legal department is consent and who is the appropriate decision maker. If we would have this question, I would think, I think we have said this patient lacks capacity, but one thing I would ask initially is, has that been confirmed? And if I open the patient's chart, is Epic going to show me that the patient lacks capacity? Because I think that's a really important initial step before we go to any decision maker. And again, if the patient has capacity, they of course can make their own decisions regardless of what if they have the information they need, even if it's something the team disagrees with or their family disagrees with, we would respect those choices. Now, in this case, we said the patient lacks capacity. We don't know of an advance directive, but as Caitlin said, we would certainly ask. And if there's any if someone claims to be power of attorney or the healthcare agent or any of these things, we always say we need to see the document. We've had cases where people have said that and we kind of relied on it and we go along with that assumption, and then there is no documentation, there might be a dispute. So we tell them that we need to see that document, and then if there's any question about it, if it's not appropriately witnessed or something, we may not be able to accept that. So there are certain guidelines, again, under Maryland law of what that appointment of a healthcare agent needs to look like. So absent the appointment of an agent, I would recommend that the team follow the Maryland hierarchy. And this actually is laid out not only in our policy, but which follows the law. So healthcare agent is first, and then, as I mentioned, is the hierarchy really needing to be followed in order. You can't just jump down to any. So after the healthcare agent, we would have the legal guardian, followed by a spouse or domestic partner. You can't have both. If the patient had still been married, even though he was living with this woman for 40 years, she could not be a domestic partner, but we heard that he was divorced. So she may be a domestic partner. And thank you, Mark, for showing this. So if they refer to each other as a partner or girlfriend, boyfriend, or any of those terms that Caitlin used, and there's no one challenging that, we would not ask for documentation of that relationship, just as we don't ask married people to provide a marriage certificate. If that relationship is challenged, there are some certain documentation that we would ask for. But if we don't have a domestic partner, then we go to the adult children. And again, equal authority under the law. We heard that some were more involved in the patient's care and some not so much. Some are, obviously there's an age difference. And really that doesn't matter. Adult children really have equal footing under the law. Now, if someone says, look, I've been estranged from my parent forever and I really don't want any part of it, I mean, that's okay. They can defer to their siblings, but they should all be contacted. And then a parent of the patient, adult siblings would be next. And finally, and we more often than you would think, get down to this sixth category, which is really a relative, maybe a friend. And in that case, we ask for an affidavit explaining how they know the patient, maybe how long they've known them, what their relationship is. And it really is to be someone really familiar with the patient's health, and maybe their beliefs, what they thought about end of life, and all of that, ideally. But again, if we are down to that level, there's an affidavit that we would ask them to complete before we would ask that person or allow that person to be the decision maker.
I wonder, if there are circumstances where, the person that's in the legal hierarchy, the clinical team, or even us as ethics consultants might question whether they're the appropriate person. Caitlin, would you want to comment on those kind of scenarios?
Yeah, I would love to comment on this piece, because I think this is what makes these situations so tricky, right? There's, as Janet so astutely, explained to all of us, there's sort of the legal hierarchy and the legal considerations, the aspects of honoring surrogate decision making. But then there's also the moral and the ethical implications of these decisions and decision makers. I think more often than not, we find that, and why these are so prevalent in terms of being ethics consults to our team, is that, more often than not, the person who is named as the healthcare agent is perhaps, the person who doesn't necessarily know the patient most intimately, or most, hasn't spent the most time with them. So in this scenario, we have a patient who mentioned a son who is seemingly somewhat involved, but not living locally, doesn't visit often, not terribly involved in his father's care, and not even actually all that readily willing to participate in decision making. And then we have another, life partner who's been there 40 years at the bedside, presumably being a more involved caretaker, certainly has likely had very intimate conversations about wishes and values with this individual. And then you have some adult children who are likely more invested in helping and being present in their father's care. And so there's always a degree of participation, and not always the patient named as healthcare agent is the one who we as a care team observe being the most intimately involved with the patient. And that causes us distress. Certainly, then it becomes a balance of supporting the law, which we have an obligation to fulfill, which is to support the named decision maker. So if, let's say in this case, the son was the named healthcare agent and was the sole decision maker, surrounded by other family members that we perceived as being more intimately acquainted with the patient, that would be the struggle, is how as a care team then can we support the named healthcare agent, and also encourage collaboration, perhaps, of the son with family members or life partners who may be able to keep the patient's voice at the center of the conversation, who may be able to assist in empowering, that named healthcare agent to really make decisions based on the wishes and the values of the patient. And so I think that is something that we often encourage care teams to think about is, there may be one person who, is going to ultimately be the one to make the decision, but we really should be encouraging collaboration, because at the end of the day, we want everyone invested in the care of this patient, whether they have been estranged for 5 years and live out in California and really don't have a speaking relationship anymore, or they live locally and they're at the bedside every day and they've taken FMLA. We want everyone who's invested in this patient's life to be able to, you know, walk away from this situation, no matter how it evolves, feeling good about what they all decided on and achieved for the you know, for the outcome of the patient. So it's tough, and there's the emotional pieces, the moral pieces, the legal pieces. And I think as a care team working together, certainly as an interdisciplinary team, you know, tapping into the spiritual resources, tapping into legal, tapping into, you know, including palliative medicine in the conversation where appropriate, social work certainly on the unit, we can all work together to make sure that we're really empowering our decision makers, and also including, you know, collaboration also.
Great, thank you. I want to come back to a couple of comments you said, but you mentioned the spiritual piece, and you know, trying to get everyone working together, you know, for the best interest of the patient, and part of that might be, you know, involvement of chaplains. So maybe John, you could speak about how spiritual care could have an impact on a case like this.
Yeah, we get called mostly into these kind of situations, and spiritual care and the chaplains kind of play a role of mediator or the navigator through this kind of crisis situations, and also collaborate with social work and with the care teams in identifying who is the appropriate decision makers. So our primary exploration starts with the psychosocial and the psychospiritual assessment, and try to understand how important faith is in their lives, and who are the closest ADs or associates of patients. And while we are assessing that piece, we also focus very keenly on the differences. Are there any differences among the people who are involved here? Every family has its own secrets and their own disputes and other things, and paying keen attention to that. If we kind of sense any kind of those red flags, alerting the social worker and the risk management, and that's where our primary responsibility or the assessment kind of ties with the legality. And also in this case, it appears that they are very civil, communicating and collaborating together. And that is also our role, as Caitlin and Allison pointed out, that bringing them onto the same page and trying to make sure and ensure that they are collaborating and come to consensus in making the decision maker. And when I say that we play the navigator's role, there are other circumstances and situations also. We get involved in different cases. I do not want to shift the focus from this case, but I can briefly narrate those kind of scenarios. Especially, it is complicated when someone is physically separated but not legally divorced. And that kind of scenario, they still hold the legal rights, and the present girlfriend or somebody, I mean, the children who are involved, they're kind of having these feelings that we are not giving the information to them, or we are kind of holding the things from them. And those are the feelings, but law does not allow us, as this person who is not legally divorced kind of stands the legal authority on these situations. And also, when there are multiple decision makers involved, whether they are stated on the advanced directives or a family chooses to make joint decisions, in those scenarios, a couple of people agree and one person in the family kind of like contests the decision. Those are the complicated scenarios, and we get involved to negotiate with this kind of scenarios. And also, if there is a present wife and there are adult children from the previous marriage, that is also a complex scenario. It is fine as long as they kind of like in good terms and good relationship. But if the adult children are not in good relationship, there may be some kind of chaotic situation, then we have to work with them as well. And the most complicated cases that we encounter are the decision makers are not being available. This often happens with the patients who are immigrants because they are here alone and their loved ones are back home, and then there are language barriers, and the decision makers are not immediate family members often, but the extended family. I can add to that piece again, those people who are incarcerated, if they happen to be the decision maker, that makes it more complex with our system, because we need to contact the jail warden who makes these decisions. And then we need to communicate anything either to the jail chaplain or the social worker of the jail who communicates. And the hardest part is to communicate with this person and to get their response. That's never-ending issue. Those are the situations. There is one area that I would like to share with all the care teams, especially this addresses the intersectionality of faith and legality. The example that I could give, take the same case, if the patient has little bit of capacity, weaning and waxing, and if he expresses the desire to marry his girlfriend or the partner, then the challenge is whether it is ethically, morally permissible, and how do you kind of navigate that. In this case, the adult children are there, but if it is a different case, that might lead to other legal implications of finances and other legal rights that will be terminated for the patient's children from the previous marriage. And it is a very complex scenario. That's when we engage all the interdisciplinary teams, especially risk management, that gives us the direction to navigate these cases.
Great, thank you. So this issue of the patient that is able to communicate a little bit, maybe express some wishes in your most recent scenario of expressing a desire to marry, but in the case example, it was the patient sort of saying he wanted his oldest son to at least quote unquote be involved in the decisions. I wanted to come back to this issue of what counts as a healthcare agent. Is just stating the person to be involved in decision making, is that enough to count as a healthcare agent, or does the patient have to show some ability or some capacity to reason about why they're choosing this person? Janet, do you have any thoughts about?
Yeah, I think we've had this before. Is there a different standard for naming an agent as opposed to making your own decisions? And I meant to look at the law on this, but I think it says that a person who appoints an agent is someone, an adult, who would be able to make their decisions. So I would argue, and especially when we've had suggestion already that he lacked capacity, and now he has this involved statement, I would be concerned about that not being enough for a healthcare appointment of an agent. And we did talk briefly though about appointment of an oral advance directive, which does require the attending and a witness with some good documentation. I think the challenge with an oral advance directive is making sure that future encounters have that information if we don't have it documented in something we put in media. I'm not sure I answered your question, Dr. Hughes, but I think I would be concerned about that being sufficient.
Anybody else want to respond to that?
Yeah, I do actually, along the same lines, if you have a patient who kind of has waxing, waning mental status, which many of our patients have, and they're deemed incapacitated, but they're still lucid enough to interact with their environment and express, thirst or the need to go to the bathroom, or they have pain, as care teams, we care about what everyone is saying to us. And so just because someone is labeled as lacking capacity, what they say and what they can still convey to us in terms of their needs or their wishes is still important and still has value to the conversation. So I always take an opportunity, because you'll observe family members or named healthcare agents that may be very quick, to dismiss what one's mother or loved one, father, son is saying. In those moments of lacking capacity, and they're very emboldened decision makers. They're ready to step up to the plate and make decisions, and maybe are somewhat are having disregard for what the patient is still able to say and able to communicate. So in those instances, certainly from the palliative perspective, when I would be consulting on these cases as a palliative support, from the ethics perspective for supporting the care teams and navigating these cases, I would say be very vocal to these empowered decision makers, especially in these instances, and say, look, like your father is still able to tell us that he's having discomfort, or that he wants to go home, and that's his priority and that's his favorite place to be. These are things that we hope that you keep in mind as you navigate medical decisions on his behalf, keeping his wishes and values in mind.
So even though incapacitated, a patient that is able to communicate might be able to express some preferences or wishes that at least have to be taken into account by the authorized decision maker.
Yeah, still adds value. They still have value, they still have worth.
And I might add there, say that the domestic partner, if we're going to call the girlfriend, the living partner, that if she decides she does not want to be the decision maker, so that we do go to the children, I think it would be appropriate that they know their father said this about the oldest son. It's also a challenge when, if I remember correctly, that is the person who thought the father should make his own decisions, which is problematic when the team has deemed he lacks capacity. But I agree with Caitlin. It's something to consider.
I wanted to ask about sort of availability. So this oldest son has been hard to reach. It sounds like numerous attempts by both the clinical team, maybe the other family members have tried to reach out to him. Allison, do you have thoughts about how much outreach should be done to try to get a person we think should be involved in decision making to be present, or at least to be available on the phone? And when do we sort of say, well, okay, they're not available?
Absolutely. So I think if we took this scenario and took the significant other out of the scenario, or if the significant other, the domestic partner, is deferring to the 3 adult children, it's important to remember that all 3 adult children have equal say in the decision making. If we're looking at adult children as surrogates, it doesn't go by who's the oldest or who's the most available. It's all 3. And so absolutely, the importance of ensuring we have contact information for all 3, that we have that clearly documented in the chart. And if it sounds like in this case, we're able to reach 2, but unable or having a difficult time reaching the 3rd, I think any efforts that the team can make to reach out to that person, perhaps I think in this case, the son, lives on a different coast, and maybe he's working during the day and unable to have his phone. And so I think, really doing some more digging, not writing them off if they're not available after 1 or 2 calls. Or as John so eloquently put, if there's someone who's incarcerated or who's in another country and difficult to reach, I think all efforts should be made to contact those surrogate decision makers, documenting the attempts, documenting the results of those attempts. And should we find ourselves, or should the teams find themselves in a place where that one of the surrogate decision makers is not available, I think that's when, a call to ethics and legal would be important in terms of ensuring all the boxes have been checked. But continuing to reach out. We've sent letters, we've sent certified mail. to those decision makers who may not be available or may not be making themselves available. And I think, to add here, if we have all three decision makers and say we're able to reach this brother in California, but he says, I'm really going to defer to my siblings, that's also important to document. If that surrogate is deferring to the other two or to one, we can document that in the chart as well.
What about a surrogate decision maker, so that we go down the legal hierarchy, but they say, I don't want to be the person, but I want to name this other person. Janet, how would you handle that? And maybe it's not the next person in the
Right.
hierarchy, but it's someone they think should be.
I mean, I think we would have to explain to them that unfortunately, under the law, we cannot, do that. We have to follow the hierarchy. And the same is true if someone was appointed as the agent and maybe now, maybe they never knew they were appointed. That happens sometimes, or maybe they have changed their mind and don't want to be involved, but they may want to appoint someone, or and we would say that unfortunately, under the law, we are not able to do that. I mean, we could certainly take it into consideration as we're going through the whole process. But I think that just on its face, we cannot honor that and explain why.
Caitlin, do you think that gets into this distinction of the legal versus the moral surrogate? Let's say it's, the sibling was named as the healthcare agent, but they say, well, I'd like my child to be the decision maker, and that child is the nephew, let's say, of the patient, but they're not the next one in the hierarchy. How would you handle it in terms of that moral legal distinction?
Yeah, I mean, I appreciate that the law sort of supports us and backs us in being able to offer these explanations to named health agents. I think oftentimes, we need to do a little bit more robust information sharing in terms of what does it mean to be a healthcare agent for someone. It's a big job. It's an important job, and one that has really potentially important consequences or impacts on a patient's outcome. And so I think, that's where we, when we start to hear all of these different scenarios kind of bubble up, where it's, that should be sort of an indication to us that maybe this person has never done this before, doesn't really know what it entails, doesn't even know what expectations to fulfill, or doesn't know that even though they're the person that can make the decisions, they have free will to involve others in the conversation and lean on others' counsel who may know the patient a little bit more or a little bit differently. And so, we are obligated to kind of educate them about what it is to fulfill the role of healthcare agent for someone. And so if there's any doubt in terms of their understanding, then we need to fill in those gaps. I find oftentimes when we do that extra legwork and just take the time, it really comes down to educating, what does this role involve, and then really empowering them, because it's a scary thing. I mean, oftentimes these people are being called upon when a patient is potentially just had something precipitous or catastrophic happen, or they're having some kind of very quick decline in their clinical status, or they have impending death. So it's big, heavy decisions that we're turning to these individuals to make. And, like Janet mentioned, they may not have even known that they were the named healthcare agent. So talk about, kind of coming to that realization and then figuring out how to fill that role. So, it takes, and I think that's why it's so important to have all of these different disciplines involved in this process and involved in the conversations, because it does take multiple iterations, and that was one other thing that I did want to bring to the table is, these things require time sometimes. And I think, more often than not, when ethics, when our team is consulted and, we speak to these care teams taking care of these critically ill patients, there's this sense of urgency. And certainly I understand that, I feel the same thing as a healthcare as a healthcare provider, as an RN, as a palliative representative. We want to do right by these patients in a timely manner. And some of these situations are time sensitive. If someone is having, needs surgery, a life-saving surgery, or is potentially imminently dying, and we want them to be at home if that's where they would want to be. But at the end of the day, sometimes it is okay to just allow a little bit of time for people to acclimate to these roles and come around a little bit, and just, have regard for the process, and the other beautiful thing that I often point out, when we're all feeling the sort of the emotional elements, the moral distress of these cases, is that the human body is finite, right? And it's organic, and ultimately it will declare itself. And not that we have in our minds how we want these cases to go, and we want to do right by these patients. But at the end of the day, a lot of times, family members will be quibbling over in the corner, trying to come up with the, consensus or a plan or that makes sense, and the patient expires because the body is done, and so I also find that soothing to just remember that ultimately the body has limitations, and we do what we can with the time that we have and the resources that we have. And then beyond that, some things we just can't completely fix.
Yeah, there is some time sensitivity to this case, because he's already having some respiratory difficulties, and so you want to try to work with them. And maybe these, adult children and domestic partner really haven't known that they needed to, be put in this situation of making decisions for the patient. They haven't been in that role previously, and now it's going to be even more challenging, even if he's had this advanced heart disease for some time. But he's maybe previously made his own decisions, and now they're being put in this role that you've got to try to work with them. There was a question, and we're going to invite more questions from the audience, but question from the audience. So there are three siblings in this case. We're again taking the domestic partner out. We would say that the domestic partner probably would be the appropriate decision maker in this case, given the longstanding nature of their relationship and the fact they live together, that she would be the appropriate decision maker. But if she were either not in the picture or deferred, then you would go to the 3 adult children. So the question was, if there are these 3 children, all with equal decision-making power, one of them defers to one of the other ones. So let's say this oldest son, we reach him and he says, I don't want to be involved, but I think my sister should make the decisions. So the patient's daughter. Does that give that daughter, that sibling, a double decision-making weight than the last sibling who was not deferred? So what do you think about that? Janet, do you want to answer that one?
Sure. I mean, I think they have equal decision-making authority, the remaining 2 siblings. And I think that no, just as you can't say, I don't want to make decisions, but someone else can, it wouldn't have any impact in my mind here. I mean, you might let them, it might explore why he thinks that. Did this daughter have a closer relationship with the father? I think that's all worth looking at. But really under the law, I don't think that would work.
Anybody else want to answer about that?
I want to add to that and say, we are often meeting patients and their families at some of the worst points in their life. And stress and emotions are incredibly high. And there are decades of family dynamics that are happening before we meet someone in a very small way. And, it can be hard sometimes when there's a lot of contention, especially between surrogates on the same level or between some of the cases, John, that you highlighted of complex family structures. It can be hard not to find yourself getting caught in that loop. And I think that coming back to good patient care, as Caitlin has outlined, but also coming back to the law, as Janet has outlined, can help me keep my feet on the ground and can help stay focused on what's best for the patient, but also what does the law say, and can help cut through, not always, but sometimes help cut through some of the noise of the complex family dynamics that we often see in most cases, but especially in the ICU when things are happening very rapidly and potentially not going very well.
Yeah, John?
Mark, there is always this confusion for the families understanding what it means to differing decision making. Sometimes they come up with the question that, oh, if I am differing my decision making authority, does it mean that I lose my legal rights? And that legal rights entitles to something else outside the hospital. Often this kind of question kind of like comes up, and Janet may be able to help us with in that direction because it's very complex sometimes. This question comes up. I work with most of the consented donors. If the decision to withdraw life support, and then if we have to have a decision maker for the consent process, then we still need to go back to the person who is the kind of legal decision maker by law.
Yeah, I mean, I think deferring in healthcare decision making is pretty limited focus. That's what we're talking. We're not talking about wills or property or whatever. You know, it's this who will make the decisions for this patient. So I'm not sure I answered your question, John, but
what about responsibility for the hospital bill? You know, so a family member might feel, well, if I don't make the decisions, then I'm not responsible financially.
No, yeah, we've had that come up. Actually, that's separate. This is really medical decision making.
Yeah, you did answer, Janet. That was the precise fear for families. Do I lose any inheritance or any kind of will that is kind of like for the future? These are all the fears that people have when they're kind of saying these.
I think another factor sometimes is people don't want to be responsible or take responsibility for being the decision maker, like especially if it might be, well, saying no to the ventilator, you know, consistent with the patient's wishes, but then sort of feeling the burden or the weight of that decision for themselves, that they were the ones that made the decision. And that might speak to something that Caitlin had mentioned earlier of what is their role? You know, are they speaking on behalf of the patient? Are they speaking to the best interest of the patient? Or is this actually their decision? Caitlin, do you want to say anything more about that?
Yeah, you know, I know I keep talking to, you know, I'm trying to kind of empower our care teams, because I think we can have a lot of impact if we kind of know what these decision makers need, and sometimes they don't themselves know because they're just becoming familiar with the role. I mean, we've had people who have been named healthcare agents for someone with an advanced metastatic end stage cancer, and they didn't even know their loved one had cancer. I mean, can you imagine? You know, but this is where I would say to the care team, you know, talking with them about the role and what that means. And then, sorry, I just lost my train of thought. Mark, restate
that it's not their responsibility. That
right, exactly. Role. So as a care team, you know, we give, you know, we as physicians, PAs and MPs on these care teams, you know, we are the experts, right? So we are giving expert medical recommendations. So if you're dealing with a clinical case where it makes total sense that this individual who is end stage not be re-intubated for the fifth time because you worry that they're not going to be able to liberate from the ventilator and ultimately are going to end up dying on the ventilator. Then it behooves us to step in as the experts and offer that very firm medical guidance to this healthcare agent and say, yes, in some ways you're sort of assenting to our expert medical recommendations. And in doing that, we sort of share the burden because it's really, we are giving that recommendation to you. We would advise against intubating this individual. And so we have to kind of share in it and let them know that you're not alone and that this is appropriate and this is permissible and this is ultimately in the best interest of your loved one.
Just again, throw it out to the audience. Anybody have any questions or comments that we can have the panelists respond to? All right, while people are thinking about it, maybe we'll just hear from each of the panelists of how would you go forward with this particular case? So we've heard maybe the oldest son is not available or not wanting to be involved. We've got the two children and the significant other, the expressed wishes that we heard from at least previous conversations that the patient had said he never wanted to be intubated. How would you approach the case going forward if you're meeting with additional family meetings or getting ethics involved? Maybe we'll go in the same order. So Allison, any thoughts?
Yeah, I think, given this scenario, we've determined that the significant other, the domestic partner, is the surrogate decision maker. Though I absolutely agree to Caitlin's point of including other family members in conversation, while the significant other would have essentially the final say in decisions. It's important to collaborate with the other children. Along with the son who lives, I think, in California, or expressed, an interest in perhaps not being involved in decision making, including him in that, and raising the patient's voice of what we're hearing at bedside. While we know he's lacking capacity and maybe his alertness is waxing and waning, I think, that's important, and it's an important voice to raise. And so I think a family meeting, having these discussions in a timely manner, given intubation is, we're soon headed there, would be my next recommendation.
Before I hear from Janet, the next question. So if it were, adult children who have equal decision-making authority, does that mean that the decisions are from the majority vote? Or does it have to be unanimous? So maybe Janet, you can answer that, and then also maybe say what you would do about this case.
I think, well, that's a really tough one. I think if we have different opinions of people in the same surrogate class, we would call ethics, and they can try to help maneuver that whole area, because I think ultimately we want people on the same having the same opinion, but I think at some point, I think I would call ethics on that and see if they can continue working with the family. I think the real challenge here is with this not intubating is we get into the area of withholding medical care, which surrogates have to have, in order for a surrogate to withhold certain care and treatment, including CPR, mechanical ventilation, we need, under the law, we need physician certification of certain conditions, end stage, terminal, or vegetative state. So that complicates this further. And actually, I'll put in a plug for appointing a healthcare agent at this point, because if you have a healthcare agent, even a healthcare agent can make those kind of decisions to withdraw and withhold, while a surrogate cannot without the physician certification, if that makes sense. but that gets really challenging. And I think also knowing what the patient has said in the past, what their wishes were. We want the surrogates to follow the patient wishes. So did he have a primary care provider who, for 10 years, who really had discussions with him about what he would have wanted? Was there a mulch that gave direction? Were there other indications of what he wanted in this kind of situation?
And we heard, at least for this patient, he has advanced heart disease. So we might the clinicians could weigh in of whether he has a terminal illness based on his ischemic cardiomyopathy. And then a surrogate might be able to make, these decisions about life-sustaining treatment. Great. And I think, if the ethics consultants were called in, we would try to reach consensus. So consensus doesn't necessarily mean unanimity or of agreement, but it means that they're all going to come together and have a final decision. So if there is a opposition, two and there are three and two say one thing and one says the other, but the one that's in opposition defers to the other two, again, trying to reach consensus, and they may not agree with the decision, but they'll go along with it, then we would go with that. But we try to reach not a majority vote, we don't go by that, but try to get everyone to have a final decision as a family unit. That's what ethics would try to encourage. Caitlin, any final thoughts about this case?
No, I would just say along the same lines as Janet just brought up in terms of, she kind of was, giving a nod to sort of these ideas of medical ineffectiveness and considerations for that pathway. I also think it's important for care teams to think about, what is our standard of practice? And, that also can help kind of inform, do we think would it be our standard to reintubate a patient for the third, fourth, or fifth time, if they've only had clinical decline, et cetera. But no, I would echo what everyone else has put forward.
John, any final thoughts?
Sir, I think I would agree with all the panelists, what they have said. The important fact is the dignity and respect of the patient. And if there are expressed wishes in line with respect to his autonomy, are there any reservations for this family, and helping them to educate, to honor the wishes of their loved one? That's where my training as a chaplain would take that educator's role.
Great. Well, thank you all. Great panel discussion. Thank the audience for attending. We will plan to see you next month. So our third Tuesday of each month. We go until June of 2023. So hope to see you in coming months, and perhaps in person. We'll see each month. So take care all.
Thank you.
Thank you. Thank you, Dr. Mark.